Assalamualaikum and good day. Welcome to part 2 of the lecture Chronic Inflammation and Granulomatous Diseases. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, UITM. So at the end of this part of the lecture, you should be able to define granuloma, briefly describe the types and pathogenesis of granulomatous inflammation, briefly describe the morphology of granulomatous inflammation, briefly describe the outcomes of chronic and granulomatous inflammation. And skill-wise, you should be able to identify the macroscopic and microscopic features of granulomatous inflammation. So let's start. So what is granulomatous inflammation? Granulomatous inflammation is a distinctive pattern of chronic inflammatory reaction. So that's why it is actually discussed under the topic of chronic inflammation. It is characterized by collections of activated macrophages. So this is the definition of granuloma. Often it is associated with T lymphocytes. Sometimes you may see it with a central necrosis, in which we will call it caseating granuloma, and we will discuss that in a little bit. And it is a form of a type 4 hypersensitivity reaction. Often granulomatous inflammation is a response to offending agents that is difficult to eradicate. So a good example will be an infection which is very difficult to clear, such as tuberculosis or Mycobacterium tuberculosis infection. Okay, so in green here, you can see this is the definition of granuloma, which is collection of epithelioid histiocytes. So this is a must-have in a granuloma. To call something a granuloma, you need to see a collection of epithelioid histiocytes. And just to draw your attention, okay, you can see here epithelioid histiocytes, and sometimes they're also called activated macrophages. So these are interchangeable terms. Okay, so they all mean the same thing. So by definition, granuloma, you can say granuloma is a collection of epithelioid histiocytes or collection of activated macrophages, and they're all correct. Not to discuss too much on hypersensitivity reaction, but just to draw your attention that granulomatous inflammation falls under type 4 hypersensitivity reaction, in which you get an interaction between macrophage and T cells, in which you get activation of these macrophages and formation of granuloma. So these are some disease entities which are known to be associated with granulomatous inflammation. So these are the causes of granuloma or examples of causes of granuloma. There are many others that are not discussed here. So top of the list is tuberculosis, caused by infection by Mycobacterium tuberculosis. And you can see the patterns of tissue reaction here. Tuberculosis or TB results in a caseating granuloma. And you can see some of the other entities which also lead to caseating granuloma, such as syphilis, which gives you a necrotic center, so that's caseation. And also cat scratch disease, which gives you the central granular debris and neutrophils, so again, that is a central kind of necrosis. While some of the entities such as leprosy and sarcoidosis and Crohn's, they result in non-caseating granulomas. So we'll have a look later of the morphology. So the top diseases here, these are causes of immune granulomas. So they have an immune basis to their formation, whereas foreign body granulomas do not have that immune basis in their formation, but rather it occurs because of the presence of the foreign body itself. And that will result in a non-caseating granuloma with foreign body material. So now let's discuss on the types of granuloma and their pathogenesis. So when we use the pathogenesis as the basis, we can divide granuloma into two types. One is an immune granuloma and the other is a foreign body granuloma. And they differ in terms of their causes, what causes them, as well as their pathogenesis. So let's have a look. So in foreign body granulomas, it is caused by the presence of inert foreign bodies, and it is characteristically, it forms in the absence of a T cell mediated immune response. So you don't get a T cell mediated immune response in its formation. On the other hand, immune granulomas occur because of presence of difficult to eradicate agents such as a persistent microbe, so a microbe that is very difficult to get rid of, such as Mycobacterium TB, or a self-antigen, and it leads to a persistent T cell mediated immune response. So you can see the difference there. So the cause is different, and also the presence or absence of T cell mediated immune response. So absent in foreign body granuloma and present and persistent in immune granulomas. And in terms of pathogenesis, they differ also. For foreign body granulomas, they form because of presence of foreign bodies which are large enough to preclude phagocytosis, but they're not immunogenic. They do not induce this immune sort of reaction with the T cells. But the foreign body itself is large enough that one histiocyte or one macrophage is unable to engulf and get rid of it. So one macrophage is not enough to phagocytose and degrade the material. So what happens is there will be more than one macrophage coming to the site, so they all sort of try and help each other to phagocytose and get rid of this foreign body material. And what happens is that these macrophages can fuse with each other. So several macrophages fuse with each other and they form what we call a multinucleated giant cell. So now these giant cells are big and they have, of course, bigger capacity to engulf and phagocytose the foreign body. In terms of immune granulomas, they have this persistent T cell mediated immune response associated with it, and it follows this sequence of events. So first of all, there are antigens which become sequestered in antigen presenting cell or APC. The APC interacts with the T cells. The T cells become activated. They produce cytokines such as interleukin 2. They produce cytokines such as TNF, interferon gamma. They activate other T cells. They activate macrophages. They recruit macrophages to the sites. More and more macrophages will come and form a collection, and by definition, a collection of activated macrophages is a granuloma. So that's basically what it is. So let's have a look at that again with a diagram. So antigen presenting cell here. So you can see that there is a poorly degradable antigen sequestered within this APC. So it's eaten, but it's not degradable that easily. So it basically is sequestered in there. And then you can see the APC interacts with the T cells. Okay, so this is your T cell. So the T cells become activated, then they produce cytokines. And these cytokines will activate other T cells. Okay, so there's the interaction is not really shown here, but they produce interleukin 2, which activates other T cells, interferon gamma, TNF, which activates the macrophages. So the macrophages then come and they form a collection, and that results in granuloma formation. So that's in essence an immune granuloma formation, the pathogenesis of immune granuloma formation. Another way to look at the types of granuloma is by their morphology, and we can divide that into caseating versus non-caseating granuloma. This table illustrates the differences, only the differences between caseating and non-caseating granuloma. So grossly, because caseating granuloma contains central necrosis, then the gross appearance is often soft and cheesy and yellowish. But in non-caseating granuloma, there is no necrosis, so there is no kind of soft, cheesy appearance to the lesion. Microscopically, in caseating granuloma, you will see the presence of caseation necrosis in the center of that granuloma. The caseation necrosis occurs due to combination of hypoxia and free radical mediated injury. But in non-caseating granuloma, you will see no necrosis. So in both, what you see would be the collection of epithelioid histiocytes or activated macrophages. You can see some giant cells associated with it. You can see maybe lymphocytes present as well, but you will see necrosis in caseating granuloma and you will not see necrosis in non-caseating granuloma. Examples are as discussed earlier. Okay, so to illustrate that a little bit better, so grossly, caseating granuloma looks something like this. This is an example of tuberculosis involving the lymph node or tuberculous lymphadenitis. So this is a lymph node here, cut into two, and this is the cut surface. So that's what the lymph node is supposed to look like. It's kind of brownish red in color. But in this lymph node involved by tuberculosis, you have multiple foci of this yellowish cheesy material of varying sizes. So there's a smaller one there, and here's a large kind of area. And you can see the yellowish appearance to this lesion, quite irregular in appearance. And if you can touch it, then you will know that this is very, very soft and sort of friable, because this is all made up of necrosis. So microscopically, this is what they look like. So this is an example of a caseating granuloma. There are four main components which make up a caseating granuloma. The first one is a must-have component, because this is the definition of granuloma, and that is collection of epithelioid histiocytes. So the histiocytes are these guys here with elongated nuclei, plenty eosinophilic pink cytoplasm with irregular or ill-defined cytoplasmic borders. So this is your collection of epithelioid histiocytes. So must have. Other components are present in varying degrees. Okay. So what are the next component that can be seen? They are Langhans giant cells. So these are the one arrowed blue. So this is multinucleated giant cells. So they're large, so hence why they're called giant cells. Langhans giant cells are the ones which have nuclei arranged in a horseshoe arrangement. So at the periphery of these cells. So two here, and there are 2, 3 more scattered about. That's the second component. The third component is a rim of lymphocytes. So these blue dots here, so these are all lymphocytes at the periphery of the granuloma. So they're often present as well. And the fourth component is something that you see only in caseating granuloma, and that is the central necrosis. Okay, so that's the morphology of a caseating granuloma, illustrated by this example of a TB granuloma here. Here are a couple more examples. See if you can identify the features or components. So on the left side, you can see this sort of ill-defined lesion here. So these cells with a lot of eosinophilic cytoplasm, these are your epithelioid histiocytes. So must have, because it defines, it makes up, or it is by definition that is granuloma. So you need to have that. There's Langhans giant cells there. There's a rim of lymphocytes scattered about, and there is central necrosis. So right side again, this is your epithelioid histiocytes. Okay, ill-defined cytoplasmic border, but lots of eosinophilic cytoplasm. A couple of giant cells. Rim of lymphocytes, see these blue dots here. And you have this central necrotic material. So central necrosis, which is seen in caseating granuloma. Contrast that with non-caseating granuloma. So on the left, again, the component, the must-have component is epithelioid or activated macrophages. So these are your cells with plenty eosinophilic cytoplasm. There's a giant cell there. There's a rim of lymphocytes at the periphery, all these blue dots here. But what's lacking? There is no central necrosis. So this is a non-caseating granuloma. And here's another example on the right side. This on the right side here is an example of Crohn's disease. So this is the mucosa of the gastrointestinal tract. So this is your granuloma. This is a collection of epithelioid histiocytes with a lot of eosinophilic cytoplasm. You can see the rim of lymphocytes at the periphery. There is not really much in way of giant cells, and what's definitely lacking is the central necrosis. So this is a non-caseating granuloma. So why it's important to distinguish between caseating and non-caseating granuloma is the fact that they have different etiology. So if you revise the entities which are associated with granuloma formation, you will see that certain entities tend to be associated with caseating granuloma, and some tend to be associated with non-caseating granuloma. So identifying the morphological types, whether it is caseating or non-caseating, can give you a clue as to what might be the possible cause for that granulomatous inflammation. Here's an example of a foreign body granuloma. So foreign body granuloma, as we discussed, it is due to the presence of foreign body in the absence of a T-cell mediated immune response. So the foreign body depicted in this image, suture material. So this is probably some kind of a post-operative procedure. So this is your suture material arrowed in white. Okay. So a single histiocyte, a single macrophage, is unable to phagocytose and eliminate this agent, so this foreign body. So what happens is that they call up more macrophages to the site, and then the macrophages fuse. Okay, so they fuse and form this multinucleated giant cell. So if you can appreciate the difference between this giant cell and the one we saw earlier, which are the Langhans giant cells, their nuclear arrangement are different. So this one is much more haphazard. It's just all over the place, whereas the Langhans giant cells have a very nice sort of peripheral arrangement of the nuclei. So this pattern of nuclear arrangement is seen in this kind of multinucleated giant cell, which is a foreign body type giant cell. So they engulf, you can see that they've engulfed all these suture materials within their cytoplasm. So this is foreign body granuloma. Again, you can see that there is not really a significant rim of histiocytes surrounding this focus, and also what's definitely lacking is the caseation or the necrosis. So briefly on the outcomes of chronic and granulomatous inflammation. The outcomes of chronic and granulomatous inflammation is quite simple. Chronic and granulomatous inflammation both occur in prolonged duration, and you often see inflammation and repair going on at the same time, along with lots of tissue injury. As a result of that, you get angiogenesis, which brings along with it fibroblastic proliferation and collagen deposition. So in most cases of chronic and granulomatous inflammation, the outcome will be by fibrosis. Healing will be by fibrosis. Resolution is unlikely because it is often very difficult to clear the injurious agents or mediators rapidly. So most of the times, or most of the cases of chronic inflammation and granulomatous inflammation will heal by fibrosis. So that actually wraps up part 2 of this lecture on chronic and granulomatous diseases. We have discussed granuloma in terms of its definition, which is the collection of epithelioid histiocytes or collection of activated macrophages. We've discussed the causes, examples of the disease entities associated with granulomatous inflammation. We've discussed the pathogenesis of granulomatous inflammation, which can be divided into immune and foreign body type. So the pathogenesis forms the basis of classifying the types of granuloma into immune granuloma and foreign body granuloma. We also discussed the morphology of granuloma, in which we can divide it again into morphological types. Either it is of caseating type granuloma or a non-caseating granuloma. And we've discussed the appearances of these, in which for both caseating and non-caseating, you should see collection of activated macrophages. And the main differences between the two will be the presence and absence of central necrosis. We've also discussed the outcomes of chronic and granulomatous inflammation, in which most of the cases will heal by fibrosis. For both parts 1 and 2 of the lecture Chronic Inflammation and Granulomatous Diseases, the references are your textbooks, Robbins as well as Underwood, and also the MOOC basic concepts in pathology. Thank you.